Hi, my name is Dr. Saif, and today I'm going to discuss on the case studies on hypertensive complications in critical care settings, in which we will discuss few of the cases who come to ICU or emergency department or even in operation theater with hypertensive crisis of many kinds. So how to manage such cases and how we can improve the outcomes in such patients, all those points I'm going to discuss in this presentation. So first case presentation. This is a 50-year-old man, known CKD stage 5 on maintenance hemodialysis since last 2 years. He is a known hypertensive since last 10 years on treatment with amlodipine 5 mg BD. However, he was not taking the treatment regularly and he presented to ICU with complaints of cough and fever for last 5 days and breathlessness for last 1 day. On examination, we found that patient is conscious but disoriented to place, and he was quite agitated when he came. His saturation was just 66% on room air. He was tachypneic with respiratory rate of 35 per minute, and his heart rate was 90 per minute but regular. The first reading of the blood pressure was 192 by 121 millimeter of mercury, and later the blood pressure continued to be in this range for the next 1 hour. We performed chest X-ray. We showed the bilateral opicities, the convalescent opicities, fluffy opicities, suggestive of pulmonary edema as well as COVID-19 pneumonia. Then we performed the bedside echocardiography in this patient, and we found that there is reduced LV systolic function. So based on this information, what is your diagnosis of this case? Hypertensive emergency, hypertensive urgency, accelerated hypertension, or malignant hypertension? What could be your first choice? So this is a case of hypertensive emergency, and as a clinical practitioner, you will come across such patients with hypertensive crisis, because it has been estimated that approximately 1% of patients with hypertension will develop a hypertensive crisis at some point of time during their lives. But the problem is that there is overlapping and confusing terminology regarding the elevated blood pressure, acutely elevated blood pressure. So some people call it as hypertensive crisis, or some people call it severe hypertension or acute hypertension, malignant hypertension, and so on and so forth. So various definitions are there, okay, in the literature, but we have to come to some consensus, and that's why now we call it just as a hypertensive crisis. So all elevated blood pressure more than 180 by 120 millimeter of mercury are called hypertensive crisis. Okay, now depending upon the target organ damage, we can divide the hypertensive crisis into hypertensive emergencies or hypertensive urgency. What are the target organ damage? BHK. In brain, we should look for the signs and symptoms suggestive of hypertensive encephalopathy, stroke, ischemic stroke or hemorrhagic stroke. In heart, we should look for the signs and symptoms suggestive of acute myocardial infarction and LV dysfunction, and also aortic dissection. In kidneys, we should look for the signs and symptoms suggestive of acute renal failure and ESRD, that is end stage renal disease. If there is a organ damage, target organ damage, then the hypertensive crisis is known as hypertensive emergency. And why this is called emergency? Because we have to perform an aggressive management. Okay. In case of obstetrics, hypertensive emergency, the cutoff blood pressure is different. It is defined as acute onset severe hypertension of greater than or equal to 160 upon 110 millimeter of mercury persisting for more than 15 minutes. Okay, so this is the definition of hypertensive emergency, and also they have defined the target organ damage that includes the HELP syndrome and eclampsia, that is the seizures along with high blood pressures. So that is about the pregnancy. So in such cases of hypertensive emergencies, we should be decreasing the blood pressure aggressively over minutes to hour. But if there is no sign or symptom of high target organ damage, then we should not be aggressively decreasing the blood pressure. Rather, we should wait for some more time, or if required, we can prescribe the oral medication for lowering the blood pressure. So, if you do not treat the hypertensive emergency in time, then the 90-day mortality rate is more than 11%. And in a study which was published in American Heart Journal in 2009 on 1,588 patients, they found that the incidence of acute or worsening end organ dysfunction during hospitalization in hypertensive crisis patient was 59%. That was quite high. Now we will go to the case 2. This is a older patient, 86 years old man, who is also a hypertensive since last 20 years with treatment on amlodipine atenolol combination BD. He presented to emergency department at 10 a.m. in the morning with complaints of unconscious state since morning. On examination, we found the GCS was low, E1, M5B1, and on ophthalmic examination, the right pupil was 6 mm dilated and it was sluggishly reacting. So what's your diagnosis in this case? So this is a case of acutely elevated blood pressure, that is hypertensive crisis, with a CT finding suggestive of intracranial hemorrhage. Now the case 3. She is a 20-year-old woman, G2P1L1, developed PIH at 24 weeks of pregnancy. She was lost to follow up in antenatal checkup. She presented to LR at 36 weeks with complaints of unconscious state and loss of vision since last one day. On examination, she was found to be having very poor GCS. Pupils were bilaterally 4 mm, normal size, sluggishly reacting. She was having the respiratory rate of 26 per minute, saturation was 90% on room air, and heart rate was 100 per minute but regular. Fetal movement and fetal heart rate were present. The first blood pressure recording of this lady was 170 over 120 millimeter of mercury on non-invasive monitor. We performed an MRI later and found this hyperintensities in the posterior cortex, suggestive of symmetrical posterior subcortical vasogenic edema. What is your diagnosis and how will you treat this case? Whether you will intubate the trachea or the first control blood pressure with the injection magnesium sulfate bolus followed by infusion, or deliver the baby, or all of the above. So in this case, definitely you have to intubate the trachea. You have to control the blood pressure aggressively because it's causing problem because of unconsciousness, and you have to deliver the baby as well to decrease the blood pressure. So definitely this is the option, and we will discuss more on this. So severe PIH, as I said, in hypertensive emergency, the definition is changed in obstetrics, and the blood pressure should be at least more than 160 over 110 millimeter of mercury for more than 15 minutes to say that this patient is having severe PIH. And the first line treatment for severe PIH is a magnesium sulfate only. This is a drug of choice, administered as 4 to 6 gram of loading dose IV followed by 1 to 2 gram per hour infusion. During the magnesium sulfate therapy, you should be monitoring for urine output, deep tendon reflexes and respiratory status. And any deterioration in one of these three vitals should be documented, reported and taken care of. However, the second choice of antihypertensive in PIH is labetalol, commonly used. Posterior reversible encephalopathy syndrome is a reversible neurological entity commonly occurring in the patients who are on antihypertensive therapy, or the patients who take some drug and that can cause severe hypertension, or who have some precipitating cause for it. So there is always the underlying problem, that is hypertension or old age, and on the top of that the patients has some precipitating factor leading to acutely elevated blood pressure and signs and symptoms, and that causes pathophysiological cascade of events leading to PRES. So that is very important to understand that the underlying problem could be either hypertension or pregnancy or old age, and the precipitating factor could be renal disease or eclampsia or immunosuppressive agents such as the cyclosporine or tacrolimus. So that can cause PRES, or sometimes in young age the patient may be taking some sympathomimetic agent like cocaine. Then what happens is that there is vasogenic cerebral edema of occipital and parietal lobes of the brain due to severely elevated blood pressure, and that leads to symptoms such as impaired consciousness, seizure, headache, visual symptoms, blurring of vision or blindness even, and few focal neurological findings. So in our case, the underlying problem was the pregnancy already. Later patient developed some precipitating factor and leading to severely elevated blood pressure and causing the unconsciousness. Okay, and the patient came to us. This is the case for 58-year-old man, chronic alcoholic, diabetic and hypertensive since last 20 years, came to OPD with complaints of pain abdomen since last 15 days and weakness since last 1 week only. On examination, we could not found any abnormality other than heart rate was little bit high, 100 per minute. However, the blood pressure was quite elevated, 200 over 120 millimeter of mercury, and then we did the CT scan because the patient came with weakness, so we thought it could be stroke related to acutely elevated blood pressure, but we could not find anything on NCCT brain. It was normal. So in this case, regarding case management, which one of the following is a wrong statement? So the wrong statement is aggressive control of blood pressure with parenteral antihypertensive, because this is a case of hypertensive urgency in which the blood pressure has to be lowered slowly with oral antihypertensive with monitoring for the next 24 to 48 hours. Along with that, we should be doing workup in this case for the pain management, pain abdomen, and also doing pain management. So what jeopardizes the outcomes in such crisis? The reflex of rapidly lowering and elevated blood pressure. Please do not do that. Whenever you see high blood pressure, take some time to evaluate such cases first for the target organ damage. So what happens is the autoregulation curve shifts to the right in chronic hypertension, and whenever you try to decrease the blood pressure to a normotensive level, that is up 120 upon 80 millimeter of mercury, the patient suffers with hypoperfusion because the arteries in the brain and kidney and heart have become habitual to the higher MAP or high blood pressure. So do not decrease aggressively the blood pressure in case there is no symptoms associated with hypertension. So you have to evaluate such patients with neuroimaging, cardiac evaluation, chest x-ray, chest ultrasound, CT angiography of chest, abdominal ultrasound, renal function test and renal ultrasound. So this is the basic minimum for evaluation of such patients. So the treatment strategy is very simple. In emergency, the blood pressure should be lowered aggressively, and in urgency, the blood pressure should be lowered gradually over days. Therefore, the pathophysiology of the disease and the principles of treatment must be well known. And you know what happens in hypertension. The hypertension or diabetes all are the diseases of endothelium. Endothelium is the culprit. What happens in hypertension? There is a mechanical stress due to very high blood pressure over the inner lining of the vasculature. Okay, that is endothelium. So that causes endothelial damage of some degree, and that leads to endothelial inflammation, endothelial border disruption, and that causes vascular permeability increase and leakage. Okay, and later, because of endothelial damage, the underlying fibers, collagen fibers get exposed, and there is release of tissue factor leading to extrinsic pathway activation and causing the coagulation activation as well as platelet activation and clot formation. These clot clog the vessel, leading to hypoperfusion of the target organ, and that is what you see in hypertensive emergency, the hypoperfusion of the target organ, all the signs and symptoms of target organ dysfunction. So the common reasons for hypertensive emergencies are only two in the normal population. Either you do not want to take medication, or you are not very compliant or regular with the treatment due to old age. So this is the problem with the old age mostly. You are bored with your medications. But in the young age, the problem is different. You take cocaine or other sympathomimetics or mood elevators to get the kick, and you get the blood pressure, high blood pressure. And if you take continuously such kind of thing, definitely you are at the risk of developing some complications due to hypertensive crisis. In ICU where we work, the incidence of hypertensive crisis are definitely higher due to inadequately managed pain, inadequately sedated patients, the patients on tube with invasive lines, and in improper posture, they develop so much pain and delirium. And sometimes if the patient is on sedatives for longer time and we stop that suddenly, that can also cause the agitation in the patient and patient ventilator dysynchrony and all those problems, and can lead to hypertension. Sometimes the patient is on a non-invasive ventilation and very hypoxic. Such patients develop sympathomimetic surge and hypertension. So all these are the problems in the critically ill patients can lead to hypertensive crisis. So what makes difference in such patients' outcome? The prompt and tailored therapy. The treatment in specific situations, as I said, in stroke and hypertensive crisis, acute ischemic stroke, if you are planning for thrombolysis, then you have to decrease the blood pressure to less than 185 by 110 millimeter of mercury and maintain that blood pressure for next 24 hours after thrombolysis is over. Because if you are not able to control the blood pressure before thrombolysis and after thrombolysis for next 24 hours, there are chances of intra-abdominal and intracranial bleed due to as a complication of thrombolysis. But if you are not planning for thrombolysis in such patient, then the target blood pressure should be at least just less than 15% of 220 upon 120 millimeter of mercury. So do not decrease the blood pressure more than 15% of baseline. Okay, the target should be just less than 220 over 120 millimeter of mercury, so that the ischemic penumbra around the ischemic zone of stroke as well as the rest normal part of brain get enough blood flow. So that is the rationale of not decreasing the blood pressure too aggressively in a stroke. Another thing which I would like to stress out over here is the use of labetalol or and nicardipine in such cases, because these are drug of choice. Avoid nitroglycerin or sodium nitroprusside because that can lead to cerebral vasodilation induced increase in ICP and can worsen the outcome. If patient is having hemorrhagic stroke, then what you should do? You should be able to decrease the systolic blood pressure less than 140 millimeter of mercury aggressively. However, you should be avoiding the hypotension. So aggressive control to less than 140 millimeter of mercury is advised in acute hemorrhagic stroke to improve the outcome, and similarly in as we do in ischemic stroke, avoid NTG or SNP. In aortic dissection and hypertensive crisis, you should be able to decrease the blood pressure very fast within 10 minutes to less than 120 millimeter of mercury to improve the outcome. Otherwise the patient will definitely die. And the drug of choices are nicardipine, labetalol, esmolol, nitroprusside, nitroglycerin, enalaprate. So many drugs can be used, but the drug of choice would be always nicardipine and esmolol in such cases. So by now you must have understood that in emergency you should be giving parenteral antihypertensive because they are easily titrable medications with rapid onset and short duration of action. Whereas in urgency you can wait, and if at all you want to give the drug, you can give the oral antihypertensive medications. So medications, there are various drugs available like nitroglycerin, sodium nitroprusside, hydralazine, enalaprate, nicardipine and clevidipine. The first and very commonly used medication is nitroglycerin, which is a vasodilator, and it decreases the systemic vascular resistance and very useful in volume overload settings and in settings where there is the LV dysfunction and pulmonary edema. Our problem with this medication is that it causes the reflex tachycardia as well as the problem of tachyphylaxis after use for more than 24 hours. So that is the issue, but this is very commonly very cheap drug to use in hypertensive emergencies. But please do not use this drug in the neurohypertensive emergencies like stroke or like PRES or like PIH, eclampsia. Sodium nitroprusside or SNP. It reduces both pre and after load and very short acting, ultra short acting and easily titrable, and you have to have the arterial catheter blood pressure monitoring for titration of the doses of SNP. 8 hours of infusion of SNP may cause cyanide toxicity, and due to which SNP is not very commonly used, especially in patients who have hepatic dysfunction or renal dysfunction, because the cyanide toxicity will be more in patients with organ dysfunction. So not very commonly used in critical care settings. Another drug is hydralazine, which was said to be used in very useful in obstetrics hypertensive emergencies. It is a very good arterial vasodilator, but the problem is that it causes RAS activation and volume overload, and hence you have to use the diuretic with hydralazine to control the volume overload with hydralazine. So in obstetrics it is not anymore antihypertensive of choice, and better agents are available like labetalol and nicardipine and magnesium sulfate, and titration of hydralazine is very difficult. Another drug is the enalaprate, that is a C inhibitor, and potent effect is seen with high renin hypertension. So it is used in severe hypertension associated with heart failure. Only disadvantage is that it can cause unpredictable effects leading to very difficult titration, and it has long half-life. So infusion sometimes is quite difficult to manage and can cause the hypotensive problems, hypotensive responses in hypovolemic patients. Nicardipine is very impressive, very good drug to be used in critically ill patient presenting with hypertensive emergencies. It is very easily titratable because of short onset of action, and like labetalol, it has long duration of action. Okay, so nicardipine, a calcium channel blocker, should be used in neuro hypertensive emergencies and also post-operative hypertension. Clevidipine is a ultra short acting recently introduced antihypertensive, parenteral antihypertensive. It is atracurium of antihypertensive agents. Okay, and is quite safe in acute heart failure. It is metabolized by plasma esterases, that is why it has very short acting, and it is quite useful in critically ill patients because it is quite safe in acute heart failure and renal dysfunction. So if available, clevidipine should be the drug of choice in critical ill patient presenting with hypertensive emergencies. Esmolol is a beta blocker, ultra short acting beta blocker, and it is easily titratable, very useful in conditions where tachycardia is not desirable, like in pregnancy, in hepatotoxicosis, in mitral stenosis patients. Hypertensive emergencies with normal or high cardiac output and aortic dissections are particular situations in which we should use esmolol as the drug of choice. It is contraindicated in few chromocytoma crises because unopposed alpha action and even severe hypertension with esmolol use if used alone. Labetalol is a short-acting alpha plus beta blocker, very good drug to be used in neurohypertensive crisis. It should be used cautiously in hepatic failure. Dexmed is used as a antihypertensive only in very specific situations associated with withdrawal syndrome or the patients with sympathetomimetic abuse, cocaine abuse, and also hyperactive delirium. Furosemide is very good drug, but it is not an antihypertensive. It is used in juncture with antihypertensive, especially in the volume overload conditions, LV dysfunctions, and also in the renal dysfunction. So various antihypertensive can be used based on your pharmacological knowledge. So lessons are very simple, that hypertensive emergencies require urgent, immediate treatment. However, hypertensive emergency can wait and requires gradual control of blood pressure. Nicardipine and beta blockers are safe drugs in critically ill patients, and control of blood pressure depends on the type of target organ dysfunction, a specific situation in the hypertensive emergencies, and you should always tailor the therapy in specific situations. Thank you so much for your kind attention. If you have any doubt in aforementioned presented material, mail me at drsaifkhan2018@gmail.com. Let's meet in the next video, and drop me a message in the comment box if you require any topic to be discussed on my channel. Thank you so much.